Happy Friday, everybody. As you can see, I am not in the studio today. I was feeling a little under the weather early in the week, and just to be safe, we canceled the show just to make sure I wouldn't get anybody sick. So today we're gonna go over some of our best segments of 2023. We hope you enjoyed this episode. If you have suggestions for what you want us to talk about, please leave us a comment, and maybe we'll do a segment on that next week live on Nip Talk. Have a great week. Surgery, but I thought it'd be interesting because I don't think we've ever talked about what are the most dangerous surgeries out there, you know. And interestingly enough, I've done a lot of these just because my background before plastics was general and trauma surgery, and so a lot of these actually have some personal experience with. So as we've talked about in the past, overall surgery is very safe. If you look at all surgeries that are being done, so this would include things like I do, such as elective plastic surgery, up to things like heart transplants or even trauma surgeries where people are shot or in bad car wrecks. If you take all surgeries across the board, your overall risk of dying is 0.5%. So that's 1 out of 200. That sounds kind of scary whenever you see that number, but you do have to realize that there are a lot of people who go into surgery with life-threatening emergencies, and realistically, they're probably not going to make it through the surgery. So that does skew it. So some of the factors that affect what the mortality rate for a surgery will be, I mean, there's some obvious things like patient age. Younger people tend to do a little bit better with surgery. Overall health, if you're overall very healthy, in great shape, you're gonna have a better chance of coming through than somebody who has 10 chronic diseases. Whether or not the surgery is elective, emergent, or traumatic, those make a huge difference. I mean, trauma surgeries are gonna have some of the highest mortality rates, followed by emergent surgeries, and lastly would be things like I do that are more elective. Complexity of surgery, obviously, taking off a mole is not going to have as high of a mortality rate as a heart transplant. And then lastly, overall surgery team skill. So, where you have your surgery does make a difference, whether it's, a level 1 trauma center or, somebody's office does make some amount of difference. So for elective surgeries, because I'm going to leave out trauma surgeries because those are just so random. I mean, it's hard to get an estimate of what is the risk of dying if you have a gunshot and make surgery. I mean, that's so just esoteric. I mean, a lot of people are basically dead when they come in, but they still go to surgery. So that's hard to evaluate. So I'm going to kind of leave out some of the traumatic surgeries. For elective surgery, though, it is lower. So if you leave out trauma, the risk of surgery goes down to like 0.1 to 0.2%. So I want to go through some of the surgeries that carry the highest risk and kind of start at the top and go down. So the first would be any surgery related to a abdominal aortic aneurysm. So have you guys ever heard of the aorta? Does that ring a bell?
I've heard of it before, yeah.
So the aorta is the major blood vessel that comes out of your heart. So your heart sits here, and there's a vessel called the ascending aorta, and then it kind of goes down, and it has all these branches which supply blood to all your organs and basically keeps you alive. And as we age, the aorta in some people can almost get dilated. I mean, specifically it's called an aneurysm, which is just a doctor word for a unusual dilation. But what happens is just like a tire that gets overinflated, as the aorta gets overinflated or stretched out, the walls get thinner and thinner and thinner and thinner. So as it gets larger, the risk of it rupturing goes up and up. And the problem is this is your main blood vessel. This is it. If this thing ruptures, you are in really, really, really bad shape. In fact, for people who have a rupture, at home, 50% of people die before they make it to the hospital. So half the people do make it to the hospital, and then they'll go in for emergent AAA repair, abdominal aortic aneurysm. And I've actually done these surgeries. I worked several shifts doing vascular surgery. And in the trauma hospital I was at, even some of our general surgeons did these. They're very hectic when that comes in and somebody has a ruptured AAA. It's just like they were shot. You have to get them in there and work really fast.
Sounds terrible.
But for those people that make it to surgery, about 40% of those people die. So that would probably be the top. A AAA repair. 40% mortality for an acute rupture. Now, if it's elective, say someone knows they have an aneurysm, but it hasn't ruptured, it's still up to 10% mortality for that, just depending on various factors, because they tend to be older patients, and they are very big surgeries that potentially have a lot of complications. And interestingly enough, there's a famous person that died from a AAA rupture, and that was Albert Einstein. the famous scientist. Yeah, I tried to find somebody noteworthy that had something.
Yeah, he's pretty noteworthy.
I figure Albert Einstein's pretty big. So next on the list would be cranial decompression. So that's kind of a generic term for any surgery where you're taking part of the skull off. And so that can be for various reasons. It could be for, a brain infection, could be for trauma. Someone, bumps their head. I said I was going to leave off trauma, but there are other reasons why someone would have a cranial decompression. But this surgery basically takes part of the skull off to alleviate pressure inside your brain. Swelling of the brain is a very, very dangerous thing because our cranium, our skull, is not expandable.
Yeah,
and so if the brain starts to swell, it immediately starts to press against your skull, and it can actually kill the brain tissue, which then makes the swelling worse, which then kills more tissue, and it's kind of a cyclical thing that can quickly result in people dying. So when people do get swelling in the brain, a decompression, cranial decompression is the surgery that they would do. I've done sort of these surgeries. I didn't do a lot of neurosurgery, but I did do cranial vault reconstruction for kids with craniosynostosis, which is where the skull doesn't unfuse correctly, or it fuses too early, and they'll have the skulls where it's normal on one side and then misshapen. And so I worked with a really famous craniofacial surgeon when I was in my plastic surgery training, and we did a lot of those, which is a form of cranial. You're doing the surgery for cranial decompression, but without the actual swelling of the brain. And it is dangerous. He's a fantastic surgeon, but I know for a fact that there was at least one patient that died while I was there. I wasn't in on the case because it's just dangerous surgery. I mean, you're literally taking your skull off your brain, and bleeding can happen, and things can really, get out of hand quickly. But mortality rate for that's 26%. So for people who have to have a cranial decompression, 1 out of 4.
Very serious.
That's serious stuff. I mean, you don't want to have to have your skull taken off. So moving back to the aorta, so the next would be aortic dissection. So this is kind of a more unknown thing. So when you look at the aorta, if you were to cut it, in half and look, on the inside of it, there's different layers of it. Yeah. So a dissection is when the blood flow actually doesn't go through the center channel, but it gets in between the separate walls of the aorta itself. Okay. And it's almost as though it's finding a different route to push the blood. Well, what happens is when the blood goes in there, the pressure separates the walls, and then it occludes the place where the blood should go. Yeah. So these are very, very dangerous things that happen. It immediately causes people to, have all these very serious symptoms or potentially cardiac arrest. And so the surgery to fix these is a really big deal because you have to get into it normally happen high up, like on the ascending aorta. So you're having to get inside the chest. Mortality rate for that's 22%. So about a little over 1 in 5 patients who go to surgery for that die. John Ritter.
Yes.
Who was
Three's Company.
He died of aortic dissection.
Yeah.
I think I scrubbed into one of those cases. I don't have a lot of experience with those. I think maybe I was on cardiothoracic when one came through. I can't remember if it was elective or emergent, but they are pretty big surgeries.
Yeah. That sounds.
Next would be liver transplant. I've actually done a few of these. We had a really big transplant program at the place where I trained. This is probably my least favorite surgery in the world to do. You don't transplant someone's liver because they have a great liver. And so when you're trying to get the old liver out, it just sucks so bad. Like they're usually really scarred up, very difficult to get out. Then you're having to take a donor liver, put it in, hook everything back up. The longest surgery I ever scrubbed was a liver transplant. It was somewhere around 13 hours for a single surgery, which is brutal. And these do carry a lot of risk. I mean, just the fact that you're taking an organ as complex as the liver out and then putting a new one in and hooking everything back up, there's just a lot of potential.
Yeah, it's huge.
Yeah, I mean, it's you're just saying it in words, it's like, you can really do that? I mean, you can, but it does have some potential problems. And so mortality rate for that's 10%. And, it's an interesting story. One of the very first patients, I did transplant first when I was an intern. And I'll never forget this story. So a guy came in, and he was a surgeon.
Okay.
And he had hepatitis C that he got from a needle stick in surgery, and his liver was failing, and so he needed a liver transplant. And when he came in, he was actually in in pretty good shape. Because when you're in liver failure, it's not as though you're always on death's door. I mean, it can be controlled to a certain degree. Anyway, so he came in, and we had found a liver for him, so we did his transplant. And then he had what's called an acute rejection. So even though he matched up to the liver donor, his body just rejected that liver. And so when that happens, you literally have a day or two to find a new liver or they die.
Right.
So we found another liver for him, miraculously, took him back to surgery, put the new liver in, and then he rejected that one as well. And then he ended up dying, which is, I mean, it's one of those things. I mean,
like somebody in my family died of hepatitis C from...
Really?
From... they had
blood
liver
transfusion.
Blood transfusion. Like, how do they not? Like, how is that?
Well,
how does that happen?
I mean, so there was a time in the past when they didn't necessarily scan blood for all these various things.
He was like an alcoholic and like had to like have all. He was like his liver was just horrible.
So I mean, if you're an alcoholic and you have hepatitis C, that's like the double whammy. I mean, that's really bad.
He died like very quickly.
Like liver failure in general is bad, but if you're alcoholic where you have cirrhosis of your liver.
Yes, that's what he was getting blood transfusions for, I guess.
Oh, okay. Well, he probably could have got from blood transfusion.
Yeah.
Anyway, so liver transplant, serious stuff. Mickey Mantle died after a liver transplant. He had liver failure, and he did get a transplant. I think he died like a month later. So, huh?
I said, oh.
Yeah.
Yeah.
I actually met Mickey Mantle a long time ago, back in the 90s. I was a big, huh?
I said, interesting.
He was I was really into baseball when I was a kid, and he obviously had retired, but he would do these baseball card shows and sign autographs.
That's cool.
And I had a friend who would take me to the baseball card shows, and so I got to meet Mickey Mantle and got his autograph. He was a cool dude. Lung resections. So people that get a lung resection, there's various reasons. Cancer is generally the big one. If you have a tumor, you want to resect that if it's even possible. So lung resection can carry a 5 to 10% mortality rate, which is pretty high. That does depend on how much of the lung you're taking out. Some people will get just a part of their lung taken out, like a small part. Okay. Other people need the entire thing taken out, so that's why there's that.
Can you live with one lung?
You can, yeah.
Oh.
You can, yeah. So anyway, that's another big one. I mean, you're getting inside the chest. If you get infection post-op, I mean, that's very serious. You can get sepsis really fast, so that's another really, really big surgery. Another resection is following that one is colon resection, 5% mortality rate. Now, that's a little bit skewing because a lot of people get their colons out and not 1 out of 20 people die from a colon resection. But what this does include is people who've had some sort of perforation of their colon. Mm-hmm. So there's some disease processes where the colon will pop inside of you and it dumps all that stool in your body and then you get super, super sick and then they come in and they do a colon resection. Those people are much more likely to die than if you say, you go to colonoscopy and you got a tumor and they got to cut it out. You're probably going to be okay from that, at least from the surgery. Another resection, pancreatic resection. This is an interesting one. This is a procedure called the Whipple. So if you get pancreatic cancer, there's a procedure that takes out the pancreas, part of the small bowel, and part of the stomach, and then hooks everything back up. They call it a Whipple procedure. I did a bunch of those in training because we had a couple guys that were really known for doing them. Mm-hmm. Very tedious surgeries. I really didn't like doing them. In fact, I was talking to my general surgery friends just this week about them, and we both hated doing them when we were there. Yeah, it's very tedious.
Critical.
Yeah, just, I don't know.
Detailed.
Yeah. So 3% mortality rate with that. So we're getting lesser, but still 3% mortality rate is pretty high. I mean, that's not insignificant. So next is a straight up heart bypass, CABG. Yeah. They call it coronary artery bypass grafting. You call them CABGs, CABG for short. 2.5% mortality rate. So that's what, 1 out of 25, I guess? Mm-hmm. Yeah, I think about it. So yeah, I mean, for the obvious reasons, when you're working on the heart, there's always the risk of something happening. The graft that you do can go bad. You get an infection.
That happened to my friend's dad. She had,
really?
Or her dad, had gotten an infection, and he was literally getting nurses coming to their house. It was like his chest was open still.
Oh, right. So
and
actually,
they were cleaning it.
But did he do okay?
No, he's fine. He's alive.
Okay, good.
Yeah.
I actually do those surgeries. So that would be a sternal dehiscence after CABG or any sternotomy procedure. So a lot of times plastic surgeons will come in to fix those, and also wound care doctors, which I'm not really a wound care doctor. I'm just a plastic surgeon that does wound care. But I see a lot of patients with sternal dehiscences after CABG. Unfortunately, it's just one of those things where when you cut open the chest and you sew it back together, it doesn't always heal great.
Yeah, it just wasn't healing.
Yeah.
I just remember, like, whenever we were kids playing at our house, we'd be like, oh, we gotta leave because we don't want to see.
Right, yeah.
Because he would literally just, like, sit in the living room, like, sitting on his recliner with this nurse, like, cleaning his stuff.
I have a crazy video of a surgery that I did. I'll bring it next week. It was a patient I got consulted on, and it was a patient whose sternum dehisced like so much that you could literally see the heart beating in the bottom of the wound. It was crazy, and so I fixed it. It's a really cool. I'll have to. It's a video. It's maybe like a minute long.
Is it as gross as that other video you showed us? With like it looked like there was a person inside of.
Yeah, probably so. Yeah.
Oh, very nice.
Yeah, you know, I posted that, and I really thought that thing would go wild, and I don't know if it's getting throttled or what, but it really, I don't know, people were not interested in that.
You posted it like on social media?
Oh yeah, absolutely.
When?
This past week.
I didn't see it. It didn't pop up on my feed, so it must not be getting.
Maybe we just posted it to YouTube Short as a test. I thought we posted it to Insta too. I wonder if it's getting throttled because it's like medical. I don't know. I can never understand social media.
Me either.
It's just crazy. Lastly, I put on there just as a what's it called? What's it called when it's not, you don't get an award, but you're honorable mention.
Yeah. Oh, okay.
Honorable mention. I put Brazilian butt lift on there.
Oh.
It's much lower.
We hate it.
Huh?
I said we hate it.
I hate Brazilian butt lift. 0.02 to 0.03% mortality rate, which actually for elective plastic surgery is very high.
Yes.
Like that's
we know
one
this.
in that's 1 in 3 to 5,000.
And then it goes up if you go to Florida to get it.
Speaking of which, I had two patients this week come to my office that went to Mexico to get tummy tucks and were having back complications.
Yikes.
In fact, the first one came, and then my next office day, my nurse was like, okay, we got a patient with, went to tummy tuck, went to Mexico to get a tummy tuck. I was like, we just saw that patient. She's like, no, this is another one. I had another one, 2 in a week. Pretty crazy, right?
It's insane.
Wild stuff.
I would
Anyway,
never do that.
let me know what you think about the most dangerous surgeries out there. I did leave out things like gunshots and crazy car wrecks just because those are so hard to kind of quantify. But if you have any questions about those surgeries, please leave me a comment. I'd love to know what you think. So this next segment is kind of playing off the segment we did about Kylie Jenner and how she admitted she had breast augmentation, because one of the things that she said was that she regretted having a breast augmentation before she had kids, and she wished she had waited. And so there's Kylie up there, a picture of her. So I think that's a good thing to talk about, and it's something when patients come into my office that are younger, I always inquire about, okay, have you had kids? Are you planning to have kids? Because it does kind of weigh into the idea of having plastic surgery. And so I'd like to just kind of like talk about some of those plastic surgeries that you may or may not consider waiting on.
Yeah.
And so the one that Kylie did, she had a breast augmentation. And so, I would say that the bulk of people I do plastic surgery on are moms who are kind of done having kids. You kind of get this idea it's all like 20-year-olds having plastic surgery, which is not reality, at least around here.
I'm not one of those.
You're not one of those people?
No, I got mine before I had it, my daughter.
Oh, you did? Mm-hmm. Okay, I wasn't going to ask you, but if you're going to volunteer.
Yeah.
So you did it beforehand? Yeah. And so,
but people think mine look more natural, though.
Did you have any regrets of doing that before or not?
Well, I was able to breastfeed too.
Right, and you should be able to.
Yeah.
There is so that's one of the concerns when you're talking about breast surgery and before kids. There is a few % risk per side of not being able to breastfeed.
Yeah.
And that depends on exactly what you're doing, but it's a small risk.
But I didn't have any
no
problems
issues
with it.
Okay,
No.
that's great, and that's good. Yet I don't want to say that you're lucky, but it could have been a different outcome.
Yeah,
for
for
sure.
sure.
Because one of the concerns about doing a breast augmentation before kids, as we said, the breastfeeding thing is one. But the fact that you're stretching out your breast with an implant, and then on top of that, you get pregnant and then your breast enlarge, for nursing, it can cause enough change to your breast tissues and the skin on your breast that your breast might end up being saggy if you did the aug before. But if you hadn't done the aug, your breast didn't get stressed out enough and then they return to normal. And so what that boils down to is that, if you do a breast augmentation before kids, a couple things might happen. One, you may have to have another surgery after that to fix things, whether it be to adjust the size, because sometimes your breasts change after nursing and pregnancy. They end up being bigger or smaller, and it may not end up being the size that you want. Or the other thing is that you may end up get sagging of your breast, and so you'd have to have a lift, which is fine. I mean, you can do a lift, but it does end up putting some scars on your breast that you may not had to have had if you had waited to do the breast augmentation until after kids. But of course, like everything, there's like pros and cons, right? I mean, being just purely blunt and honest, I mean, there's a lot of girls that want to do something to change themselves before they get married, while they're still dating. It's like I used to work out a ton before I got married, and I still work out a little bit because I try to stay in shape. But man, I was hitting the gym hard. Man, I need to look good when I was out there, trying to meet people, right? Yeah. I mean, it's a competition, isn't it? And so, but I do have these conversations with people when they come in, specifically for breast augmentation, about. You do realize that when you have kids that things might change. And I think most people realize that, or they hear it, they're like, okay, that makes sense, and I don't think it changes people's minds a whole lot. Because I've never talked to somebody and they say, oh, I didn't think about that, see ya.
Yeah, it didn't change my mind.
Yeah, it didn't change. Did they? So when you went to your consult, if you remember, did they talk to you about the fact?
Yeah, he specifically asked me if I wanted to.
Really? Okay, good. Well, that sounds like
breastfeed and all that kind of stuff.
Yeah.
And
that's great. Okay, sounds like your surgeon really was kind of on top of it.
Yeah.
So the other surgeries that you might consider waiting would be like a breast lift.
Yeah.
It's the same reasons. I mean, you're going to do the surgery to make your breast look the way you want, and then pregnancy may change that. And so, that's, I mean, another one that's on the fence, right? Because, if your breasts naturally just have a lot of sag just from genetics, you might feel very self-conscious about them. And I've done lifts on people that haven't had kids before. I mean, most of the people you do lifts on, you're doing them because of pregnancy.
Yeah.
But there are people that just genetically have sagging of their breasts. And so I've done some lifts on people before, and I'm like, look, just be aware that pregnancy may change it. Breast reduction would be the other one. I always kind of lump breast reduction and breast lift together because they're almost identical surgeries, except for the reduction, you take a little tissue out versus a lift, you don't. But otherwise, they're identical. Liposuction's another surgery where it's like, okay, do you want to get your body all contoured the way that you want, and then pregnancy change that? And so, I mean, I'm a little less, aggressive about not talking people out of it, but if somebody came in, they want liposuction for their kids, they just be aware that when you get pregnant, things may change.
Yeah.
I'm
for sure. That's definitely one that I would wait for.
Would you? See, for me, like the breast stuff's worth almost waiting for, just because it might add a whole nother surgery, versus the lipo. It's like,
As if I went to, I don't think I would go to get like another like boob job or anything.
You probably will at some point in your life.
Right now, I'm saying. Like, I'm not married, and I'm like, and I want to have another kid, but like, I'm not going to go do that right now just because I'm single and like looking, but as a 20-year-old, I was not thinking about kids. I was like, I just want to look cute.
Right.
So
I feel so old sometimes when I'm talking to younger people. I'm like, oh, you got to think about when you get older. And if someone had told me that when I was young, I'd be like, who are you?
Yeah, as a 20-year-old, I was just like, I just want to look cute in this swimsuit or this top.
Yeah, exactly.
Yeah.
So the one though that probably is the big one would be tummy tucks.
Yeah, that's
you absolutely do not want to have a tummy tuck before you're done having kids. And so I do tons of tummy tucks. I do probably one a week, and that is something I always ask patients about, like, are you done having kids? And if they say no, I mean, I guess maybe I would do the surgery for them, but I would have to counsel them that, look, pregnancy is going to take everything we did and just flush it down the toilet, because things like stretchy skin, tight abdominal wall, I mean, all of that like gets altered with pregnancy.
Literally flushed down the toilet, thousands of dollars. Yeah.
Right, exactly. And plus, and those surgeries get harder when you try to redo them, especially tummy tucks. Like I've done redo tummy tucks, not on my own patients, but on people who had them done elsewhere. They're not fun. and the recovery's not fun. I mean, that's a bigger surgery. It's a little bit more rough recovery than like breast surgery. You really just want to do that one time.
Yeah.
So I think that that's an important one that,
one of my sisters wants to do that. She's like in this process of losing a bunch of weight.
Oh, is she?
She's taking like
she's
taking one of those shots.
Ozempic? Yeah.
But she got it prescribed like for real reasons, not just to lose weight, but like.
Oh, for diabetes or something? Oh, okay.
To make it to where she doesn't have diabetes, to get her, because she was like right on the line. But she has like a goal. She has a goal of weight loss, and when she hits that goal, she wants to do like a mommy makeover. Yeah, she's already lost 30 pounds.
Nice. That's great. Excellent. Good for her. But yeah, definitely would want to wait until weight stabilized for that. I mean, that's a whole other conversation about when people are losing weight. And
she's like, she's probably not going to do it for like a year or two.
Yeah, you definitely want your weight to be stable. So, but it's an interesting conversation about when to have plastic surgery. I mean, at the end of the day, as long as it's safe, I mean, I don't have a problem doing plastic surgery on people that have kids. I mean, obviously, but you just do have to consider what the outcome of that would be. And, is that decision going to mean that you're going to have an extra surgery down the road? You just want to be aware of that. And so, if you're thinking about it and you haven't had kids, just make sure that, when you go in and talk to the surgeon, that they kind of give you the information about what does this mean after I get pregnant? Yeah. So, 'cause, I mean, I agree. There are people out there, that would maybe not even mention that. Just be like, oh yeah, you want this? Let's go do it. Yeah, money, right? Yeah, money. So, but no, it's a good conversation to have. So, all right. Well, leave me a comment if you have questions about plastic surgeries before and after kids. I'd love to hear from you. Today we're going to be talking about flesh-eating bacteria. Now, have you guys heard of flesh-eating bacteria?
Yeah, you talk about it all the time.
I talk about it. Okay. Before that, no. All right.
Yeah, I've heard of it in like movies.
Only from you.
Okay. So it is a real thing. The doctor word for that is necrotizing fasciitis. And I think I got a little graphic. Did you already throw the graphic up?
Gotcha.
Yeah, there it is.
Oh, I thought it was going to be something gross.
No, that's coming. It's coming. So I'm going to give you warning when that happens. So that's the bacteria there. So flesh-eating bacteria. So
like
this is a
Cheetos.
very...
That's what I see. It do look like green Cheetos.
Cheeto Puffs.
Dude, stuff looks weird under the microscope, man. All right, so this is a very rare but extremely lethal type of infection. And it got a lot of notoriety back in the 1990s because somebody famous died from it. And it was Jim Henson, who, you guys may not know who that is. He was the guy who created the Muppets.
Yeah,
wow.
Yeah. Dun, 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 dun. Wait, is that the Muppets?
I don't know. I
think that's how that song goes. Anyway, the guy who created the Muppets, Jim Henson, died of necrotizing fasciitis. And so I vaguely remember this from the 90s. There was like a Time magazine article about it. Like, what is this? Do we need to be worried about it? And of course, at the time, I was, like a teenager, so I didn't think anything about it. But then I get into medicine, and then specifically get into surgery, and I kind of learned all about this necrotizing fasciitis. And man, it's like serious business. Now, the lucky thing is, or the good thing, is that it's very rare. It has an incidence of about 1 per 100,000 people per year, which means roughly around 3,000 people in the United States every year get necrotizing fasciitis. That's pretty low, all things considered.
Do you like get it from like being around nasty places or like?
Yeah, sort of. Yeah, we're gonna talk about it. Yeah. But yeah, it's a good question. Like, right, you want to know, how do you get this? Because you don't want to get it.
Jumping in some sketchy looking lake or river or something?
I always advise people not to jump into sketchy looking lakes for multiple reasons.
I'm like, so pretty much every lake or body of water in Texas.
Yeah, that's right, man. The lakes here are sketchy. Dude, I grew up on Lake Louisville, man. That place is like,
I take Avery there all the time.
Dude, you can watch like the fish dissolve before your eyes in the water.
Oh no.
It's pretty bad. I'm just kidding. I grew up on the lake. I grew up there. It's not that bad.
I mean, I go there
dead body. Huh?
Oh my God.
No, seriously, people die out there like on the reg.
They tested that lake and found so much of the hormone that girls have when they're on birth control in that water.
How in the world did that get there?
From pee, I guess.
Oh, from pee. Oh my God.
Yeah.
See, it's a lake full of pee and dead bodies. Okay, sorry, Lake Louisville. It's my hometown. I feel like I can dog on it. Okay, so this is caused by the bacteria. This shows off a bad start. No, good start. It's a good start. So this is caused by the bacteria Group A Streptococcus. Now, here's the scary part. This is a common bacteria that everyone has on them right now. It lives in your oral cavity. It lives on your skin.
Yeah, I get strep all the time.
Right.
So does Avery.
Yes, it causes strep. The other things it causes sometimes is cellulitis, which is a soft tissue infection. Most cellulitis are generally caused by Staph aureus, and I know we've talked about that bacteria in the past, but it can cause cellulitis. Now, here's the thing. The Streptococcus bacteria has varying amounts of toxins that it can release. Like some strains of it are very toxic and others are less. And that's one of the reasons that we think that, this bacteria, which is normally, which is all over us, sometimes causes these really severe infections. And what happens is the bacteria gets into a certain location where it's hard for the body to take care of it, and that's along the fascia, the muscles. So fascia is basically it's kind of a fibrous tissue that covers things in our body, like for example, muscle, and it's sort of avascular, meaning there's not a lot of blood flow in it, and blood flow is how our body fights infection. So the necrotizing fasciitis means a death of infection along fascia, okay, if you're gonna break down those words. It can be multibacterial, it can be caused by Staph, Vibrio, and Clostridium. I think a lot of times what happens is when necrotizing fasciitis starts, it just creates a condition where any bacteria can flourish. And so that's why when you culture it late, you're going to see a lot of bacteria. There is a subvariant of this that we are going to talk about because I have the wildest pictures ever that I'm going to show you guys. And it's called Fournier's gangrene. And that's necrotizing fasciitis of the perineum or the crotch.
Cool.
It's specific to the crotch. I don't know why they gave necrotizing fasciitis to the crotch its own name.
Is that what is gangrene? Because I know, I heard that, you hear that all the time from like soldiers getting it.
Yeah, so gas gangrene is
back in the
basically a condition where you get dead tissue due to injury or infection. Yeah, gangrene. Gangrene just means dead, dead tissue.
Okay.
So, yeah. All right, so how does this thing present, right? Because you don't want to have necrotizing fasciitis, and I will tell you that it is very, very lethal. In the past, I always said that the mortality rate for this was about 50%, meaning, if you get necrotizing fasciitis, it's a coin flip whether you live or die. Now, there's a lot of factors that go into that. For example, if you get necrotizing fasciitis, you're at home and you don't seek treatment, and your death rate is 100%. 100%. You can't survive this without enormous amounts of medical intervention. When I looked at the data, the number I got was like 30% mortality rate, and I think that number is specific to if you get to the hospital with it, what's your mortality rate. So I think the overall mortality rate does really stand around 50% because a lot of people present really late to where there's not that much to do. So because this thing is so lethal, you really want to know if you might have it. Now, not to make hypochondriacs out of all you guys here in the studio and all you people watching, it is really rare, okay? But there are some hallmark symptoms of necrotizing fasciitis that really kind of distinguish it from other infections. And there's two things. One, it is rapidly progressing. This is an infection that you will see a spot that's red, and you come back an hour later and it's this big, and you come back another hour later and it's this big. This stuff progresses like almost to the point that you can visually see it, which is very unusual for infections. Most infections are more slow and insidious. The other thing that really distinguishes necrotizing fasciitis is a term called pain out of proportion, which means that if someone has necrotizing fasciitis and it's just starting, and you go and you touch it, they will scream. It is very, very painful because the infection is along the muscle, versus most soft tissue infections, which are more superficial, they might be sore, but they're not to the point where you would be screaming if somebody touched it. So rapidly progressing, pain out of proportion. The other thing that's really hallmark for necrotizing fasciitis is really unusual appearances of the skin. And I got an awesome picture I'm gonna show you guys in a minute, but I'm gonna warn everybody before we do that. The other thing that you can get that, no, it's bad. This stuff is bad.
Is it the crotch one?
I have that one and some other ones, man. Today's show is, I hope we don't get banned because of it. I'm gonna put some disclaimers out there. But,
they are some wild photos.
Yeah, don't be cheating now, Trump. Just looking at them ahead of time.
Man.
All right, the other thing that the necrotizing fasciitis causes, and the reason that it causes death, is it causes systemic symptoms, right? So if you get a cellulitis, say on your leg, it'll be red, it'll be sore, but you won't have symptoms elsewhere in general. Necrotizing fasciitis is the complete opposite. What kills you is not the death of the tissue at the location, it's the response that it causes on your body. Those toxins start multiplying as the tissue dies and the bacteria start cranking them out, and suddenly your heart goes into failure, your lungs go into failure, your kidneys go into failure. And how you'd see that manifested early on would be things like extreme fever, tachycardia, confusion. I think we were talking about sepsis the other day. That's sepsis, you know. Those are the symptoms. So if any of those symptoms that I talked about, you know, if you have them, I mean, seriously seek out medical attention, man. This stuff is no joke and it can kill you. So as far as risk factors, right, because you want to know what puts you at risk, you were talking about jumping into a lake. I mean, realistically, that's not a risk factor for necrotizing fasciitis. Like, a risk factor would be a break in your skin. Now, but that thing is, that happens all the time. You know, but a break in the skin does allow the bacteria, Streptococcus, which is normally on your skin, to get on the inside. Our skin is an amazing barrier for infection. It's amazing. But when it breaks down, that's a weak spot for bacteria to get in. And a lot of times you'll just get like a cellulitis or like a run-of-the-mill soft tissue infection, but it can lead to necrotizing fasciitis. The other things that can lead to it are a weak immune system, diabetes, chronic illnesses, alcoholism, and it's actually a lot more prevalent in men for whatever reason. So as I said, the death is caused by sepsis and multi-system organ failure. The other thing is, if you survive it, you're left behind with an enormous wound, because the way that you treat this is multifactorial. One, you have to get rid of the area of infection, and that means aggressively debriding, like removing huge amounts of tissue, because the tissue's dying and it's spreading fast, and you got to get ahead of it. And I got a couple pictures that show that. And then it also takes a lot of antibiotics, and that's just to save your life. But then you have to come back and reconstruct whatever hole is left behind from all that cutting. And that's why I have such a lot of experience with this. I did general and trauma surgery for 5 years, and in that time I saw tons of necrotizing fasciitis because I was the one that was cutting it out. As a plastic surgeon, now I'm the guy that's fixing the wounds, and occasionally I'm the guy that diagnoses it because somebody has something weird and they ask me to see it in the hospital. And I actually, one of the patients or pictures I'm going to show is a lady, I literally saved her life. Like, I got consulted, they said, "This is a really weird wound, can you come check it out?" And I looked at it and I put a mark on it and I said, "This looks very worrisome. I'm going to put a mark here, I'm going to come back in an hour." And when I came back, my mark was here and it was this big. And I was like, "That's necrotizing fasciitis." And we took her to the OR, and it was, and we saved her life. But yeah, I mean, then we have to go back and fix the wounds.
I've done that before with somebody I knew had MRSA on their leg.
Yeah.
And it was really red.
And you marked it?
And I put a circle around it. I was like, "This looks really disgusting."
And
it looked like a huge, it hadn't broken the skin yet.
Yeah.
It was, looked like a ginormous, like, spider bite.
Right. And then did it grow outside of the mark?
Whenever they woke up, it was
That's
outside
a really
of the mark.
smart way, Sarah. That's a really smart thing that you did, and it's a really good thing for people to know that, you know, if you're at home and you have a cellulitis, and maybe it's not like necrotizing fasciitis, right? Because your chances of getting cellulitis is exponentially higher than getting necrotizing fasciitis. But say you have an infection and you want to know, is it getting better or getting worse? Take a Sharpie pen and mark the edges of it and see if the redness is growing out of it
if it's just
or
like
shrinking.
tender, like abnormally tender.
That's
like
a normal that's cellulitis. Yeah, pretty standard. Yeah.